I would like to welcome also Dr. Meneghini that just arrived from Italy. Dr. Misrai is going to talk about the green light enucleation, a great friend of mine also from my residency in France. Thank you very much for coming and we're hearing.
Thank you, and thank you for inviting me. It's always a pleasure to see friends, international friends, international colleagues, to share knowledge and sharing the cake. Just because when I listen to such speakers you invited, I always learn something new. It's a fact. So the attendees are not the only beneficiary from this kind of events. It's always a pleasure to listen international speakers and experts like you invited. So it's my pleasure to present you in front of the one who developed the technique, Fernando. So I'm always shy when I'm talking about green laser enucleation. So it's my pleasure to present you this technique, which is not a very new technique. It has been described years ago, but I will give you an overview. But I'd like to, we are on a meeting focused on the technique. So we are not only technicians, we are urologists and doctors and physicians. So don't forget the decision-making process. And I like to illustrate that point with poor decision perfectly executed, like we had the demonstration, and we will have also tomorrow. So poor decision perfectly executed result in poor outcomes. And I would like to illustrate that point with a patient who is coming to you in your office and complaining from nocturia. The Qmax is 7 milliliters per second. So we think, okay, he has a BPH, BPO, Qmax is a testimony of that. So let's offer him an enucleation. Okay, so decision-making process is simple. And the patient is coming back 2 months later. Okay, great, I have a good stream, but I still wake up 5 times a night. Oh, really? Just because you forget to do avoiding agenda, and you forget to clarify that the patient was urinating 1 liter, the amount of urine during the night was 1 liter. So the patient is still complaining from nocturia. So the decision-making process was not clearly exactly perfect. So be careful of that, be aware of that. So green laser, green light fiber. And what is the evidence with endoscopic treatment of BPO with the green light? So we see that green light is strongly supported with vaporization, but as Professor Gavras said, in the guidelines, in fact, enucleation with the green light is not part of the gentleman club because of the lack of strong evidence. We don't have RCT for that. We have 100, approximately, almost 100 papers in the literature, but retrospective or with low level of evidence. Retrospective study, even with a large number of patients, but the level of evidence is remaining low due to that. But there is a clear evidence that green light users are able to use the green light fiber to enucleate. Why? Because, in fact, when you vaporize medium-sized to large-sized glands, you will have to face with a high level of BPH tissue recurrence. Not only with nodules, because when you enucleate, you can left nodules inside, but when you vaporize, you can leave a large amount of residual tissue that will regrow and give some hematuria, some less recurrences, etc., years after, from 2 to 3 to 6 years, but recurrence as well. And you will have to retreat the patient surgically because we all know that medical treatment is not useful in that kind of cases. So for the technique itself, let's focus now on the technique. For the technique itself, the cystoscope matters. In fact, it's quite impossible to do a blunt dissection when the lens of the optic is at the same level of the tip of the scope, just because when you slip on the tissue, you won't be able to see anything, exception with a microscope. No, you have a clear and wide vision when the lens is back, millimeters back from the tip of the scope, and that kind of cystoscope was designed by Wolf Company. I don't have a disclosure with Wolf, I have to admit. I don't have. And the cystoscope, this cystoscope, the 24.5 shift, is able to provide the surgeon a wide view, even if you slip on the capsule, to dissect the adenoma. So to illustrate the surgery, nothing's better than a video. So this video, we've made this video with Benjamin Prada, which is a French colleague, interesting and involved in the BPH surgery. So prostate volume 92 cc, 90, in fact, 90 cc. 73 years old patient, acute urinary retention after cardiac surgery. So settings, GreenLEP generator, of course, the Wolf instrument that allows blunt dissection, and GreenLEP fiber, which is not the most recent fiber, the Moxie fiber, but the oldest one, the HPS 120 watts fiber, just because the fiber is more robust, resilient, and we don't need as much energy to enucleate than for vaporization. It's 10-fold less energy than for vaporization, almost. So surgery starts as usual, looking inside, ureteral orifices, etc., etc. Nothing's less and nothing's more than the other surgery, endoscopic surgery with different energy sources. And the procedure starts, as Fernando described previously in the World Journal, and developed progressively more and more with the marking a white line, a groove, superficial groove to delimit the sphincter from the apex. And initially it was fear. Initially, for my first case, the cardio was at the maximum. In fact, when the cardio is very low, after many cases, you are more at risk to do some mistakes during the surgery, so be careful of that. So the cardio, when the cardio is at is maximum, you don't want to see the sphincter because the sphincter has to be behind you. The less you see the sphincter, I thought, okay, the best it will be, but it's completely wrong. You have to see the sphincter to clearly delimit the apex of the prostate from the sphincter, and you can avoid like that issues, trauma. So superficial white line, coagulation mode. So the settings are 40 watts for coagulation and 80 watts for vaporization. So small, limited energy delivery. So it's very important to spend some time to mark the sphincter, mark the apex. So really apical release, like all the speakers before me told you. And you see the movements of the scope on the right side of the screen are really smooth. So I will accelerate the video a little bit. Cystoscope position. So now is the time to release the adenoma from the capsule. So gently press, gently move laterally at the apex to detach the adenoma. Sometimes the adenoma is detaching really easily, sometimes not, and we can use the tip of the fiber, like a small finger, small tool, to find the right plane, not to go deeper, not to be too superficial inside the adenoma, because the procedure will be much more difficult inside the adenoma, of course. And I like to emphasize the importance of releasing the apex as much as possible without leaving this kind of nodules, because it will be much more difficult to follow the curve of the adenoma after, if the apex is not released completely, if there is some remnant tissues. So I use vaporization to cut, the cystoscope to detach, and I often move the cystoscope back to see where is the sphincter. I know where is my sphincter, but the patient, of course. And I do gently. Endourologists are the most gentle people all over the world. It's a quote of I don't remember, maybe Olivier Traxa. I don't remember. So gently detaching the apex, and I do the hemostasis step by step. At the very first time, I left the hemostasis for later. Okay, it's nonsense, because later will be too late. In fact, it's much more difficult to do the hemostasis at the end than when you do it when you carry on the hemostasis step by step. Even if the space is allowing a good vision, don't let the hemostasis for later. Do it step by step, frequently. So yeah, we have many ways to do the hemostasis with the coag mode, of course, the pulse mode. So 40 watts delivered on the tissue, on the vessels. And you have a nice one for larger vessels. So of course, it's not the aortic tube, but even some small vessels, arterial vessels, can impair the vision. And it's very difficult, because if you vaporize the tissue, the vessels will go through out of the capsule, and then you have to search from the vessel to coagulate properly. But you can use the extremity, the tip of the fiber, which is not cooled, as with the most recent fiber, the MOXIE fiber is cooled to improve the durability of the fiber, the life of the fiber. But this fiber is not cooled, so you can use the heat of the fiber. Here, precisely, there are sometimes you can face different planes, so there's discrepancies between planes, and you have to choose, okay, which plane I should go through. This one or this one, maybe this one, okay, but you see that it's not the right plane, because the tissue is not like it used to be, and if you go deeper, you will face the thin capsule, maybe the fat. So my deposit, okay, I should go back, and find the right plane. Typically, this prostate is fibrotic, much more difficult, even if it's only subjective. We didn't find any difference between patients taking combodart or other alpha reductase inhibitors for many times compared to those without. We didn't find any difference in terms of capsular perforations or operating time. But okay, with a limited number of patients, so maybe conclusions could be different with a large number of, with a much more large cohort. And then we see the right plane. And I detach progressively. I use the vapor. Typically, the amount of energy at the end of the procedure is 50 kilojoules, 60 kilojoules for a prostate of 80 grams. Compare vaporization 10-fold more, at least, and much more longer when you vaporize such large prostates. So, like Karin Lerich said, you dance around the adenoma. I think I found this quote really beautiful. You dance around the adenoma, so you follow the curve. In fact, it's not a cube. Yeah, the prostate is not a cube. It's a sphere. It's a sphere. So don't forget that. We have to be aware about that, especially at the beginning of the learning curve. Prostate is not a cube, yeah, of course. Okay, and now I detach the adenoma completely. I mobilize the prostate at the level of the bladder neck. Okay, I move forward the video. So we see that the adenoma is almost detached from the capsule. I used to detach the upper part at the very beginning of the procedure and not the base of the prostate. Because if I release I found that if you release the prostate at 6 o'clock first, it's very difficult to reach the upper part, and you have to tilt the scope, and then maybe the sphincter is at risk to be stretched because the adenoma will lift up if you detach at 6 o'clock position first. The adenoma will lift a little bit, and then the scope, you need to lift the scope to detach the upper part. So I used to detach the upper part first, and then after the lower part of the prostate. And carrying the hemostasis progressively to make sure that there is no bleeding before moving to the morcellation. Coagulation of the fossa. I will vaporize some small tissue, some remnant tissue at the apex. To clean the apex, in fact, cleaning the apex. To avoid the anterior flap. I check again ureteral orifices and then proceed to the morcellation. So now at this point, when you start the procedure, the cardio is low. Your cardio is low because, okay, you think you've done the most important part of the procedure, and then, okay, I'm fine. No complications so far. Everything is okay. Patient is sleeping. No bleeding. The adenoma has been detached. Okay, is in the bladder. You flip the adenoma in the bladder, and then everything should be okay. I left a little bit the level of my attention, but no, you should not, because there is a second part more as crucial as the first, and as the speaker said before me, it's the morcellation is crucial to train the team, to make sure that the irrigation is on, etc., etc. And I used to put a catheter without irrigation most of the time. Sometimes yes, of course, but most of the time no irrigation, and remove the catheter the day after. So the learning curve, as it has been said previously, that the learning curve is extremely widely reported in the literature, from 30 cases to 200 cases. So initially, we report with Grégoire Robert in Bordeaux and Benoît Perronnet and Jean-Nicolas Cornu as well, the first study, 100 patients operated with GreenLEP enucleation and 100 compared to 100 patients who underwent OLEP. And we found that, okay, 30 cases is enough to overcome the learning curve. And then we combined some different settings in the methodology. In fact, it depends on what you put in the bucket. If you want to analyze more precisely the learning curve, you will find some very different results. And we published a bigger study with a large number of patients. And we found that, okay, 30 is not enough. Maybe 200 to master the complication. And I used to say, you're only good when you can solve your own complication, and you are unable to solve your own complication after 30 cases. Okay, you know the basics, principle, things to avoid, to do. Okay, but everything, no, you don't know. And the second thing is that you have to know your own results. If you are in front of the patient, don't tell the patient, okay, you have 2.5% of risk of incontinence. No, this is published in the literature by, I don't know what kind of experts. Okay, your results. So even if you don't publish your results, because it's more and more difficult to publish retrospective studies, I know that. But it depends on you to ask someone else, a clinical researcher or a resident, or I don't know. If you evaluate yourself, from a human perspective, it's difficult because we don't want to be evaluated by ourselves. It's very difficult. We don't like that. So ask someone else. Okay, collect my data and with the first 30 patients and give me a feedback on my results. Okay, how many stress incontinence? And that's why when I published my first results on GreenLEP, I published the paper on Journal of Urology. I don't know why they published this paper, because the rate of incontinence after GreenLEP compared to PVP for the same range of prostate size was 25%. Ooh. So everyone took this paper to kill the technique, and nobody was aware. I was aware that I was in the mild learning curve. Okay, I was in the mild learning curve, and the technique was not described as it is now, thanks to Fernando and the colleagues. The amazing work he did to describe the technique and to standardize the technique. But okay, I was in my learning curve, but and they didn't take in consideration that the patient, the incontinence resolved. Okay, it resolved. Okay, at 6 months, only 1.5% or 1% of patients still complaining of light stress incontinence. Okay, so it was not a drama. Okay, it's 6 months, 2 months, 3 months, 6 months, difficult for the patients to experience stress incontinence, but it was not a huge drama, and I did not put a sphincter. And I follow up all my patients in database with my clinical researcher. I'm not doing that myself, and I'm not doing my statistic myself. But it's really important at your level when you start something, a new technique, to evaluate yourself, to be able to what kind of things I should improve. Maybe I do wrong. Maybe I should ask Fernando again to go back, or Jean-Baptiste come back again to train me. Okay, because I missed something, because my results are not really good compared to what you said, and it's very important. I would like to emphasize that point. You notice that. So the perioperative outcomes. What are the perioperative outcomes? In fact, the literature is scarce, and we have only limited data, robust data, but I choose to show you a large study involving 1,000 of patients, and we compared PVP and green laser enucleation, and we see that, in fact, the energy, the amount of the energy is very limited compared to PVP. The capsular perforation, okay, the capsular perforation was interestingly lower than for PVP. Even if you do blunt dissection, capsular perforation was really limited compared to PVP, because PVP you can arm the capsule with the laser if you don't pay attention, if you vaporize too deep. Bladder injury, it's due to the morcellator. And major complications were a little bit higher, significantly superior compared to PVP, just because it's a blunt dissection. Even if you coagulate very, very well with this wavelength, it's a blunt dissection compared to vaporization. You have more coagulation efficacy with the vaporization than for enucleation. The length of stay was similar between the two. In fact, I have to tell you that it was from the first patient to the last. It was a multicentric study with many surgeons, and it was their preliminary experience. So from the first to the 200th patient, so it included the learning curve. So that's why it can explain the non-significance of between maybe the length of stay, for instance. After months of follow-up, we can see that the Qmax, which is the most important thing, even if the Qmax is prone to variability of measurement, when you jump on the weight in the bathroom, okay, if you change the position of the foot, the weight will be different. It's exactly the same when you measure something in urology. If you measure the Qmax, maybe the second measure will be less or maybe much more. So there is a variability. But accounting on that, even if we account on that, GreenLEP was much more proficient in terms of Qmax than with compared to vaporization. So the GreenLEP fiber can be used, of course, for enucleation, but is still considered, because of the lack of data in the literature, is still considered as an outsider. But in a general perspective, GreenLEP laser is a much more versatile laser, because with a single wavelength, you can treat many clinical cases. You can do PVP, of course, for frail patients, and old patients, antithrombotic agents without modification of the antithrombotic agents. You can do PVP without interrupting antithrombotic agents. I'm not sure that the literature is supporting with a high level of evidence that enucleation is safe when you don't stop oral antithrombotic agents. I'm not sure of that. Maybe retrospective, but prospective study, I'm not sure. So you can use the GreenLEP laser to do PVP, of course. And if you are afraid not to be complete when you treat adenoma with PVP, of course, for small to medium-sized gland, you can use vapor enucleation. So you will detach in a progressive way to learn. And Dr. Roche was talking about that with the thulium. In fact, you can use the laser, not to follow exactly the plane. In fact, with the GreenLEP, when you do vapor enucleation, you can follow the plane of enucleation, but you will vaporize, you dissect the plant, the adenoma, and then you will vaporize what you detach from the capsule. Just vaporize. Don't use the morcellator, but it's a progressive approach to the enucleation, the complete en bloc enucleation technique. That being said, thank you very much again for the invitation.
Thank you very much, Vincent, for this excellent presentation. I wasn't sure about how we were doing with GreenLEP, this kind of enucleation. It seems that you are controlling yourself, your results, and you are publishing. And I will be a little bit provocative. They are not. You are rare. You are just doing a GreenLEP. Do you think that you are on the right side of the history or not?
I'm doing. We have the Thulium subtive in our department, and I do some TULEP as well. So I'm not focused exclusively on the GreenLEP, but from a physical perspective, I found some interesting papers in the literature, but really difficult to understand because I don't have the scientific background to understand everything on that. But some papers dealing with the wavelength of the laser, the modification of the epithelium of the vessels, according to the wavelengths. So sometimes some wavelengths will activate some cascade of, I don't know, and green light and the blue light is supposed to deliver the best hemostasis in terms of histology, from an histological perspective in these kind of papers. And some lasers are activating as well the hemostatic cascade, which I wasn't aware of. But it is really difficult to understand again these kind of papers. But I'm not focused on a single wavelength, so I use amazing. But honestly, I had the thing that okay, GreenLEP is doing good for hemostasis, and we are conducting a randomized controlled study, national randomized controlled study, with the GreenLEP vaporization exclusively with patients under oral antithrombotic agents, oral anticoagulants, which are antithrombotic, but oral anticoagulants, Eliquis, etc., etc. So the patients are randomized in two arms. Of course, patients required BPO surgical procedure, and patient will be randomized in two arms. So you stop, and after the surgery, you bridge with low molecular heparin few days, and then restart oral anticoagulants. And the other arm, you don't stop. So at the time of the surgery, the patient is still under oral anticoagulants. And we approach the study completion. So study completion, 386 patients. So it will be maybe done at the end of the year or maybe early 2023 for the results. But my thing is that there is no difference. So we could change with this paper the guidelines from the anesthesiological point of view and our point of view as well, that it's safe to vaporize patients without bridging with a high level of evidence this time. So that's why I'm mostly involved for GreenLEP, but
It's not exclusive.
No.
Okay.
No.
I would like to thank Dr. Makarounis for his comments, and have a question from the audience that we should ask. There are some irritative symptoms with GreenLEP. We know that it's from Dr. Patras. Do you think that with the GreenLEP there are less than with evaporation?
I don't like to say I think, because I think it's used to be low level of evidence. So I don't know. Anyway, my position on that is, okay, the patient will complain from irritative symptoms for a few weeks. I give patients non-steroid anti-inflammatory, if it's possible, of course, because if a patient is under oral antithrombotic agents, it's very difficult to introduce non-steroid anti-inflammatory. But if irritative symptoms do not disappear with non-steroid anti-inflammatory, it means that there is something wrong. Maybe a tissue, a fluffy tissue, necrotic, fibrotic, or a retral stricture. So it's not a big deal to, the patient can afford some irritative symptoms, not refractory to non-steroid anti-inflammatory, but they can afford that for a few weeks. It's not a big deal, honestly. It's not a major complaint from the patient. Of course, if it is prolonged over 2-3 months, okay, it's difficult. And we have to search why there is such a condition. But I didn't see any difference between the energy sources.
Okay, thank you. There are no other questions. What do I see here? So, allow me one comment for the organizing committee. Mr. Gravas, Professor Gravas, would say that show me your results. There is an argument that, in my experience, there was a session from European urology, I think, that it was the most crowded session I ever seen in my life. It was in a room, 2,500 people. And the title of the session was How I Do It. So we're urologists, we care about the data, but we also care to learn about the individual experience. If that makes any sense, Professor Gravas.
I think I have to reply. So you are right and wrong. I mean, there are always some pioneers, like Fernando, like Jean-Baptiste or Bisson, that they are committed to test all the new treatment modalities. And when they prove that they are good, then we are going there to learn the method. So that's why. So when we have this how I did session, we have all the data behind it to support this session. So it's not only, actually, this is the beauty of urology. We have all these toys for boys. So it's when we have something new, we want to take it and to adopt it in our practice. But we cannot afford to adopt everything, not only from an economic perspective, but also for our patients. Because if something is not good, it's not good for our practice, not good for our patients. So if we have the data, yes, then we are moving to this how to session, like this educational course today, because mostly for all the methods we analyzed are established methods. So they have data to support it.
Thank you for your answer.
I would like to add, we used to remember our success, but not our failures. So it's important to review our own results.
Any more questions? Yes, Dr. Roche, please.
I think that there is, when I see all these guys, and I remember the first hours I was in the operating room about education, and I remember how difficult it was. I want to make a comment. I think that what is very important to do education is to have your knowledge in the papers, in the video, and try to have the good devices to use. Depends not actually on what laser you're going to use, but you need to have a good oscillator, a good reflector. You need to spend time on video, you need to spend time with proctors, and you need to be very careful about this technique. It's not a technique that you're going to learn after 3 radical prostatectomy in the day. It's sometimes you need to take some time to do it and to perform it properly, because it's an amazing technique with amazing results. But if you do wrong, your patient is going to be really wrong. And don't forget that it's functional surgery and not logic surgery. So the patient needs to have a perfect functional result. So please try to keep on mind that it's difficult. It's not only BPH technique and so a secondary line technique. No, it's a real surgical technique with a strong learning curve, and you need to have all the force around you to go to your goal. So I think that try to be careful on that.
Κάτι τόπους να δείξουμε στην οθόνη να σας δείξω. Κάτι που σου γράψω στο δίπλο.